name's Anne Barton.
Sorry.
My name's Anne Barton. I'm a clinical academic rheumatologist and I'm a close colleague of Pauline's. I'm the current director of the NIHR Manchester Biomedical Research Centre, and it's my absolute pleasure to introduce Pauline today to present her inaugural lecture since her appointment as a Professor of Rheumatology. I've worked with Pauline for more years than I care to remember, and she was the first clinical training fellow that I supervised. So we go back a long way, and I'm really looking forward to hearing her story. So over to you, Pauline.
Oh, thank you, Anne. I'm going to share screen. And I hope you can all see that.
Pauline, we can't see.
Yeah,
oh, yes, we can.
Yeah, we're just moving over to the slide set now. We can see those all right, Pauline, if you want to start your slideshow.
Slideshow, let me just do that from the beginning. You can see that?
Yeah, we can see that. Go ahead.
Wonderful, thank you. And I have a whole lot of people here sitting next to me, so I'm not talking to myself. So it's fantastic. And thank you for joining me, and thank you to MAHSC for giving me the chair and allow me this great opportunity to celebrate our rheumatology as a team. I'm going to talk about the cutting edge of rheumatology, looking beneath the skin. This is a dinosaur. It was drawn by one of my kids. I've been around for quite some time. I don't call myself a full dinosaur, but I'm a dinosaur chick. So this is my story of how a dinosaur chick became a chair. Long, long time ago, in the faraway land called Jiangmen, next to Hong Kong, lived my grandparents in a black and white photo. They were both illiterate. Despite that, my granddad was a famous dim sum chef in Hong Kong. And my dad lived in China with the family. That's what they do. So his dad worked in Hong Kong and they lived in China. So my dad was about to go to university when he was deployed, and he became a peasant overnight. So he did that for a bit and decided to go to Hong Kong and learn the art of making dim sum instead. So my parents were the last generation allowed to have 3 births, and out popped 4 because we had twins in the family. Here's a photo of us with our cousins, and our cousins all in single child families. So my dad, after he learned the skill, he was asked to come to a little place called Cwmbran, next to Newport and Cardiff in South Wales. He was employed there as a dim sum chef in a Chinese restaurant, and we came to join him shortly after. None of us spoke any English. I was 13 and a half. In China, I was about to learn English, so I bought myself a dictionary. It was extremely useful because I carried it to all my lessons, and it's well used. We lived in a large council estate, and here's a photo with some of our neighbours at the bottom left. And at the top left is us visiting Barry Island. If you recognise the name, you might be a secret Gavin and Stacey fan. And there's a photo of us as a family at my sister's wedding. I went to a local comprehensive school, Llantarnam School. It was rough and tough, and it was subsequently placed on special measures and closed recently. My job prospect at the time was to get a job in a takeaway kitchen, not good enough to work at the counter. It was at this school that I met some of the most amazing people. And Mr. Miles, who joined the corps, is one of them. He was a biology teacher, and I needed to do A-level biology, and there was no class. So he set one up just for me. And somehow, 5 years later, I got all the top A-level grades, and I went to the nearest medical school in Cardiff. After 2 years of clinical studies, I got funding from MAHSC to do a 1-year BSc Intercalated Biochemistry degree. After that, I completed my medical degree and I graduated with first-class honours. So I got myself a really nice top job as house officer rotation in South Wales. And as part of the rotation, I did some rheumatology. And
Hello.
I thought, wow, that was fun. So I thought, I want to do rheumatology.
Hello.
Hello? I carry on. So I thought I was going to do rheumatology as a career, only to be told by the Dean of Medical School at the time that rheumatology was out of my league and I should be thinking about doing care of the elderly or radiology. So after my membership exams, as soon as I was eligible, I was told to leave Wales. This time round, leaving Wales was nothing like leaving China, because I just drove past an invisible line on the road, and here I am in England. Miraculously, I got a training number in rheumatology in Manchester. And as part of that, I did the MSc course in rheumatology over 2 years. And at that particular time, whole genome sequence studies was very hot. And our group was already doing it in rheumatoid arthritis. So Professor Ian Bruce and Anne Barton thought up the idea that we should have a big number of cohort of psoriatic arthritis patients. So with a research nurse, we went round to all the patients' houses and we collected all the data and drained their blood, all over 500 of them. Then I brought them all back to the University of Manchester. So before I go further, I need to tell some of the audience what psoriatic arthritis is. It's a condition where patients suffer with inflammation in their joints and have a skin condition called psoriasis. It can affect up to 1 in 100 people. We don't know what caused the disease, but what we do know is that it's caused by multiple genetic factors with different environmental factors all coming together in a perfect storm, producing the disease. Psoriatic arthritis not just affect the joints that we can see, but it can also affect the spine, and it can affect tendons, Achilles tendonitis, or plantar fasciitis. It can cause swelling in fingers and toes. We call sausage fingers and toes, or dactylitis. It can affect the skin, which I already mentioned, and it can affect nails. They may get inflammation in the eye, called uveitis or iritis, or the gut, called inflammatory bowel disease or Crohn's disease, ulcerative colitis. And patients with a high BMI are more likely to get the disease. Once they have the disease, they're more likely to have a high BMI. And comes with that, they suffer with type 2 diabetes and hypertension, the so-called metabolic syndrome. And it's no surprise to you that our patients suffer with depression. So with the samples I collected, I have the Wellcome Trust entry-level training fellowship to extract all the DNA by hand and then have some pilot data. I did all that within 3 months. I practically slept in the labs. And after that, I applied and was awarded the MAHSC Clinical Research Training Fellowship to complete my PhD on genetics of psoriatic arthritis. Here's a picture of me on my graduation day. The boys are Mancunian. And Patrick endured the whole thing and still smiling. After my PhD and completed the training, miraculously, 2 jobs appeared at the Kelgren Centre for Rheumatology. I got one of them working as a full-time clinician. Ian Bruce is the pillar and a visionary. He set up this unit and put it into the Centre of Excellence for Lupus. Shortly after, my twin, Rachel Grockin, joined me. As a rheumatologist, you all know that we need to diagnose patients with inflammation in the joints very early and treat them aggressively to avoid long-term damage. Once the joints are damaged, we cannot reverse it. So I was going to set up the early arthritis clinic, and ultrasound scan is very useful in this area. Like you do, weekend 1, I went to the basic course for ultrasound, which was the BSR course, and weekend number 2, I went to the advanced course. And after that, I just got on with it. And I fundraised for this little Ford Fiesta of an ultrasound machine. And over time, I'm pleased to say, we now have the Rolls-Royce version. Ultrasound is now bread and butter, what we do, and it's very useful for many reasons. All I can say is, why be blind when you can see inside the joint? And here's an example. All of you can see that the hands and the foot are swollen. Under the ultrasound, it's very easy to see that the dark area underneath the skin is due to swelling, and we call this subcutaneous edema. And here you can see that here's a joint, and this area looks dark, so it's swollen, and the box picks up blood flow. Normally, we don't see blood flow in a joint, and here it's all lighting up like it's on fire. So this joint is definitely hot and bothered, and it's very active. And here we have a sausage finger or dactylitis, where you can see the swelling in the joint around the flexor tendon and also in the soft tissue. This is hot. So we call this a hot sausage finger rather than a cold sausage finger. So what about research? The Kelgren Centre has always been very active in research, taking on commercial studies, clinical ones and academic ones as well. And we have an amazing team of research nurses headed by Lindsay Barnes here. And after she retired, Sindhu John is now the lead, and they are doing amazing work. At the University of Manchester, I worked with Anne Barton, and we collaborated with many leaders across Europe, looking at the genetics of psoriatic arthritis. We formed the European Genetic Consortium, and it was fun visiting them. And out of it, we published a paper on Nature Genetics. So try to beat that. I also co-supervised Majura in her PhD looking at microbiome and psoriatic arthritis. We are what we eat, and this is well studied in some specialties like gastroenterology, where fecal transplantation is the treatment option now. In psoriatic arthritis, it's still a long way and is a huge challenge in this area. Majura is now a consultant at UCL, doing very well, and she's still doing research. With my ultrasound skills, I've been able to take part in some high-profile clinical studies across the UK, and here's one, a PIPRA study, where we identify patients who are at high risk of developing rheumatoid arthritis, but not quite developed it yet. And what we do is that we treat them aggressively with immunotherapy and watch them. We may not be able to prevent rheumatoid arthritis altogether, but we definitely delay the onset of that for many months, if not years. Being part of the Biomedical Research Centre, headed by Ian Bruce for many years, and now by Anne, we started the synovial tissue collection biobank. Initially, I was collecting swollen tissue inside the joint, we call synovial tissue, with tiny little scopes. But with ultrasound, it has become much easier and more comfortable for our patients. Patients are patients, some are tough cookies, and here's one. So the patient came to the clinic with a story sounding like gout. So here's the left knee, which was bothering him, and it showed fluid in the knee. And then you can see little speckles floating about. So they are crystals. So he had gout in his left knee, and that was his only problem. However, his right knee was also swollen. He wasn't bothered. But on ultrasound, you can see that it was packed with little finger-like projections we call villi, like the picture here. So this is classic of psoriatic arthritis, which he had cooking for many months, but he just ignored it. So I'm very proud to say that we are the only centre in the Northwest region doing this fancy work. And over the years, we now have a biopsy squad. And we have, over the years, we have perfected the DIY technique of doing it. With this technology, our centre have been able to take part in some of the cutting-edge clinical trials where we take tissue samples, the swollen joints from a knee or a wrist or other big swollen joints, and then we look at it under the microscope, work out what kind of inflammatory cells and inflammatory markers are there, and then we pick a treatment directly for that particular patient, the so-called personalized medicine, the perfect drug for the perfect patient at the right time. Science has also moved on. We're now doing multi-omics, where we look at not just proteins, but genes and RNA sequences. And we can now take blood, synovial fluid from the joint, and the synovial tissue, all from the same patient, and work on those samples. Here's one hot off the press. We published the paper on multi-omics on psoriatic arthritis. And Gisela headed this across the way in the University of Manchester. And well done to Dr. Ryan Hum for getting his Forward North Wellcome Trust Fellowship to do some fancy stuff with the latest technology. He's going to work on psoriatic arthritis tissues across the different compartments, trying to work out inflammatory cells involved, how they all fit together, and what they actually do to cause inflammation and disease. On the theme of PhD projects, I'm very grateful to Professor Maya Butch and Dr. James Blewett and Nisha Nair that I can co-supervise their clinical fellows. And here's Yvonne and Rudy, I'm sure. And Rudy has already submitted his PhD, and he's now a consultant at the Kellgren Centre. So well done, Rudy. The future is always looking very bright. I now have research time to do more. At the heart of it all is all about our patients, enabling them to do what they love most. And here's one of my very happy patients. It's all about teamwork. I'd like to thank all our patients who have taken part in research, and I'd like to celebrate our wonderful team working at the Kellgren Centre and the MFT. And not forgetting our wonderful academics, who also is our team members working across at the University of Manchester. I'd like to thank MAHSC for giving me this opportunity to celebrate our success. And thank you all for listening. And I'd like to end with the motto of Manchester Royal Infirmary, which is just below the clock here. And it's the Good Samaritan Act. So thank you very much.
Thank you, Pauline. That's an absolutely fantastic talk. Ben, I don't know if you've got the chat open there. Have we had any questions while Pauline's been talking? Because I've not been able to monitor that myself.
No, thanks, Pete. None that's come through the chat that I can see at the moment.
Great, thank you. So does anyone on the call want to directly ask Pauline a question while we've got 6 or 7 minutes until the next talk starts? Well, while people are formulating their thoughts, Pauline, sorry, was someone about to come in there?
Yeah, I'll ask a question, Pauline.
Thanks, Anne.
So you've really successfully managed to combine being a busy clinician and then incorporating research and then building that research portfolio. What are the biggest challenges that you've faced along this journey?
I think it's time, but I just loved it, so it didn't matter. I just make time. I think time is a problem.
So would you have any advice to younger colleagues who want to pursue a similar pathway?
Well, if you have the passion, no one can stop you. So just go for it.
Yep. On a similar note, Pauline, when you were speaking about the work that you did recruiting over 500 patients, how difficult was that to coordinate? Because I've worked on studies where we've struggled to coordinate 30, 40 samples from patients similar in things like rheumatoid arthritis. So you speak a little bit about the experience of that one.
It was tricky. We have to keep calling the patients, meeting them, and then having to drive to their houses. But I had a chaperone, so that was okay. And I mean, it wasn't easy, but then I didn't have children. So I think at the time it was a little bit easier.
Fantastic. And one of the other questions I had as well, you kind of addressed this in your talk already about the ultrasound work, the equipment and the research that you're carrying out here in the Northwest. So you're one of the only teams that are doing this kind of work in the Northwest. Are there other sites across the UK that are carrying out similar work that you know of?
Oh, yes. So they have the centre in London,
Okay.
the centre of the universe,
Yeah,
and
sure.
other places like Newcastle and Edinburgh. So, but in Northwest, we are the only place.
So it's great that the centre is being such a site of innovation for the Northwest and really highlighting some of the brilliant work that's going on in Manchester particularly. So I think that's absolutely brilliant, and that was really informative. Okay, we've still got a couple of minutes. Did anyone have any final questions for Pauline? Ian, I can see your hand up. Would you like to come in there?
Yeah, can you hear me okay?
Yes, we can hear you just fine.
So first of all, Pauline, that was absolutely brilliant and really, really fantastic talk. Well done. I think it's a testimony to Pauline's passion and what she's been able to do over the last 20 years. And one very simple example, the day when we advertised the post for consultants, she came to see me this time, and I said to her, look, what we really need next, the next big thing in rheumatology in the Northwest is to get somebody into ultrasound and to drive forward ultrasound, both from a diagnostic and hopefully future biopsy work, etc. I think she went straight across the street to Manchester Royal Infirmary, tracked down the musculoskeletal radiologist and said, how can I get to learn ultrasound if I was to come to take on this post? That's passion and drive, and that's a laser-like focus on doing the next thing that's going to take things forward. And I think the biopsy work is another really strong example of that. There was a lot of talk about this for a long time, but Pauline rolled her sleeves up and executed it with passion and drive, with a laser focus. And I think what you see now is the dividend that has been, not just to her and her career progress, but look at all the trainees and all the researchers that she sort of name-checked today who really benefited from that. So a real linchpin, I think. So congratulations, Pauline. Very well done.
Oh, thank you, Ian.
Yep, I think everyone on the call would probably echo Ian's sentiments there, Pauline. It's absolutely brilliant talk. Thanks very much for giving that for us this afternoon. So I think we're ready to move on to the second half of our events. Has anyone, any final hands going up there in the chat? I just double checking if anyone had any burning questions in the last minute. Okay, so I think what we'll do now is I believe we've got Claire on the call from NCA. Claire, and you're going to introduce our next speaker, Peter Paine, for us.
Pete, not to worry if Claire can't, I can always just introduce myself.
Claire, have we got you there at all? If not, I can just hand over to Peter quickly. Might be having some IT issues. Well, anyway, to introduce our second speaker in the inaugural chair series, I'd like to bring in Peter Paine, who is a consultant gastroenterologist at NCA. Peter, you probably give yourself a bit more of an introduction than that, so I'll just hand straight over to you. Take it away.
Cheers. Thanks, Pete. Can you see the screen all right? Is that sharing okay?
Yes, that's coming up just fine for me over
And
here.
you can hear me fine?
Yes, loud and clear.
Right. Well, first of all, again, a big thank you. It's a great privilege and honour to be given this MAHSC honorary clinical chair, and very grateful to get this opportunity to share really my brain gut odyssey, or how I became an enteric electrician. I want to give a big shout out right at the start to my friend, colleague, and fellow co-traveller in the brain gut odyssey, John McLaughlin, who without his support and help, this next step in the journey wouldn't have become possible. Quick conflict of interest. I have no relation to Professor Paine's extra hot sauces, despite their gastro theme of anal angst and flaming flatulence. My name is spelt with an I, not with a Y. So don't be misled into purchasing either of those. So enteric electrician, neurogastroenterology motility is the posh title. What is that? It's a subspecialty of gastroenterology, and I was the chair of the British Society of Gastroenterology subsection for several years up to 2021. It's used to be described as functional gut disorders. We don't like the F word anymore, so we talk about disorders of gut-brain interaction. And they cover everything from the top to the bottom of the gut lumen. It's actually the biggest caseload in gastroenterology. It represents 1 in 10 of consultations to primary care for any condition, and half of our secondary care gastroenterology conditions. So you'd think that people in gastroenterology would be queuing up to deal with these conditions, but actually it's the least popular section. Inflammatory bowel disease, endoscopy are the big beasts. There's only about 20 or 30 of us who are self-proclaimed neurogastro subspecialists in the UK. And I think that's because it's perceived often as difficult, somewhat depressing, and dangerous with complaints, etc. And I think all of those things are unfair characterizations, but it does put people off. So how did I start out on this journey? This is a much younger me, without a beard and without any grey hair, graduating from St George's back in 1996 in London. And halfway through that, I integrated a BSc in sociology applied to medicine. That was the first time really my thoughts were broadened beyond just purely the biological and the idea of a biopsychosocial perspective on medicine, which is absolutely integral to neurogastroenterology motility. And I also had some fun learning about Marx and Durkheim, Weber, Foucault, a lot of philosophy, and my first step as well into academia. But the other key thing I remember from medical training was my first year as a third-year clinical medical student. I met my first patient with irritable bowel syndrome. And I was really struck by the high level of patient distress. This was a professional young lady whose life was dominated by the toilet. And having spent 45 minutes with her, I then went and presented to the gastro SPR. And I was equally struck at how utterly dismissive they were of this patient. And they went out of the consultation room feeling worse than they came in. And it really struck me there must be a better way than this. And not knowing much about IBS at that point, really started me thinking of this whole area. I did my early house jobs and SHO jobs, as they were called back then, in London and the Southwest. And in general reading and literature, came across this very strange concept, thousands of years old, splanchnizomai. King James Version of the Bible translates it bowels of mercy, bowels of compassion. Really, again, whetting my appetite about this link between the guts and the emotions that have been known about and thought about for thousands of years. So that got me down the neurogastromotility route, and the 4 big centres at the time were London, Nottingham and Salford. And in engaging with all three, I finally realised that the number one really was Salford. So I moved up north. My kids now all have Bolton accents, and started gastroenterology and academic training. The person really who was the godfather of the neurogastro unit here at Salford was Professor David Thompson, and he had a very broad view of everything from the cell, soma, central nervous system, psyche and society. And it was really talking to him that convinced me Salford was the place to come to pursue this further. I then spent a fun year with, many of you will know, Shaheen Hamdi, who's one of the professors here at Salford. And the culture of the unit was very much you are your own guinea pig. So I was having my motor cortex stimulated with transcranial magnetic stimulation, which caused focal upper limb seizures because the hand is next to the pharynx, and the pharynx is where we were really aiming. But so that was fun. And here's a picture of me actually doing a bit of transcranial magnetic stimulation as well on somebody else, not just having it done to me. So that I started off in the motor area, but I was really always much more interested in the sensory side and pain, and spent 3 years doing a PhD with both David Thompson and Kazim Aziz as my supervisor. And again, very interesting time. I had battery acid sloshed in my esophagus. In fact, here is an actual picture I've saved from 2003. I think you can see of my own actual esophagus. This was how committed we were to research. I had the battery acid. I had the endoscopy and biopsies the next day to see if there were any cytokines upregulated. There weren't, but it did hurt. I had a gastric barostat balloon burst in my stomach, like a scene from the Alien movie that turned into hooks on the way out, and had reflux ever since. And again, I'm not sure if we still do these kind of things today, but had intravenous ketamine or special K to try and block central sensitization, and developed an incipient dissociative episode. So I was very much my own guinea pig. But it was also a brilliant opportunity to do state-of-the-art testing. So autonomic function testing, cortical evoked potential, magnetoencephalography, functional MRI. In fact, I think I saw Dr. Lloyd Gregory in the audience, who helped me learn that. But much, I'm sure, to Lloyd's disappointment, I came away unimpressed with a lot of these fancy techniques. In fact, fMRI seemed to me somewhat, I ended up using the term blobology, the new phrenology. I came away convinced of what the philosophers of neuroscience call the ineffability of qualia, that the first personal experience of pain is not readily objectively demonstrated or translated to other people. There is no good algometer, no perfect measure of pain. So pain became my real clinical and research interest. And here we are, one of the papers from my PhD, which was a slow burner, because I can't compete with Pauline Ho's Nature Genetics. But a number of years later, I did get into the annals of improbable research, which I'm not sure many people can claim that. They were tickled by the idea of nominative determinism. Here was a paper by Paine on Paine in the journal Paine. You could say I peaked at that point and had achieved my destiny. I went on, however, to get appointed as a consultant at Salford Royal, and really thrown at the deep end. Again, one of my heroes and mentors I could see on the audience, Chris Babbs, will remember this young mug consultant who did 4 ward rounds a week while also doing 2 clinics and 2 endoscopy lists. And I think it was a sink and swim. And if I wasn't broken and survived it, they'd keep me, which I thankfully did. And when I'd got my feet under the table a little bit, I began to develop my true passion of tertiary neurogastroenterology, particularly with an interest in centrally mediated abdominal pain. It grew from nothing to a handful to pre-COVID peak referrals from all over the north of the country, up to 130 personal tertiary referrals a year. And with some pharma pump priming, business case appointed and trained a bowel function specialist nurse. And we've had several iterations now, and that's still the case today, supporting our neurogastro service. And I was also part of developing a unique embedded GI psychology service to support neurogastroenterology by championing unmet patient need across the Northwest. I alluded, this is often a very distressed group of patients, and we do need that psychosocial approach. So psychological support really key and important. But centrally mediated abdominal pain, chronic continuous abdominal pain, remains my key interest, and challenges in that around what you should call it, how to frame it, how to avoid inflaming it, and how to calm it. So centrally mediated abdominal pain is supposed to be very rare. It's only based on small case series with a very low pooled prevalence. But I managed to put together over a 10-year period the world's largest case series at that point, and was part of shifting the conversation around, in particular, reducing risk for this group of patients, around avoiding opioids. This is a Paine team colleague here, Justin Turner, that we've written chapters in books together on this subject. Avoiding opioids, which inflame the situation, the narcotic bowel syndrome, avoiding repeat surgery, the safe use of neuromodulators. And this is some of the data we produced. And in particular, most of these patients have the pain, whatever is happening, whether the gut is functioning or not. But in half of them, there was an association with what the gut was doing, which was a new observation. And the other big observation we found was that there was a biomarker for the pain. It wasn't just their history, but they had allodynia on the external skin surface. So a non-painful skin brush stroke was evoking pain. And this was very much a biomarker for what was happening neurologically. So this is called viscerosomatic convergence. So there can be sensitization and injury of the internal viscera. That can lead to central sensitization at the dorsal horn of the spinal cord. And so you can get visceral allodynia. So just a drip of water or a small puff of gas evoke terrible pain for this group of patients due to an increased afferent barrage. But because of that viscerosomatic convergence, the skin was also becoming very sensitive as well. And this biomarker strongly suggestive of this central neurological circuit. So we were very confident this was a neurological, neuropathic, or nociplastic type of pain. We also found evidence for how opioids were making it worse. So patients who had been on opioids, who were currently on opioids, were much more likely to have this allodynia present. So the opioids seemed to be changing the neurobiology. They were also more likely to have had surgery in the past, so a much more high-risk group of patients. So what's happening here? We know that opioids can change the function of the bowel. They can cause constipation and nausea and affect motility very commonly. But in a smaller proportion of patients, they also actually change the pain sensory behavior, this narcotic bowel syndrome or opioid-induced hyperalgesia. It's a very counterintuitive notion that the painkillers are actually making the pain more painful. It's like throwing fuel on the fire of an already sensitive and sensitized nervous system. And this was dovetailing, as this evidence came out, it was dovetailing with recommendations emerging from the Royal College of Anaesthetists Faculty of Pain Medicine about the harms that opioids can do. In America, opioid use was becoming catastrophic, and we weren't far behind. And again, together with Paine colleagues, we're beginning to try and turn this conversation around and change prescribing habits around. And I think we are getting on top of it now, recognizing that opioids at high doses are very harmful, are causing more problems than good, and should be stopped in a controlled fashion, even if no other treatment is available for chronic benign pain. But what can we do about it? If those are the things that can inflame it, how can we calm it? Well, our research also showed that duloxetine was the single most effective neuropathic pain agent. And that, again, dovetailed with emerging evidence with NICE network meta-analysis that for chronic benign pain in general, duloxetine was the most effective neuromodulator. We also found that combination neuromodular therapy was more effective than single agent neuromodular therapy. Most recently, we've been able to build on this, and I saw my colleague Joe Geraghty is also joined in, looking at duloxetine in painful chronic pancreatitis. So John had the genius idea of calling it Dualipa. Joe's really pushing this forward, and we're working up an RFPB grant together at the minute. So fingers crossed for us that we can move forward with that. And it turned out to be the patient's #1 clinical priority in this group is dealing with the chronic pain. But I said I've had a big role, had an opportunity to have a role in the BSG, British Society of Gastroenterology. They're forever frustrated and annoyed that a web search they battle for top spot, whether Battlestar Galactica comes out top or British Society of Gastroenterology. They're just pipping Battlestar Galactica at the moment because they've been off screen for a little while. But I was the NGM section chair for a number of years, and that involved arranging the national meetings, sessions, study days, hosting an international faculty, but also gave me an opportunity to start leading on some international guidelines. So I was involved in developing the international guideline for chronic severe intestinal dysmotility. And then with Alex Ford, who's a professor across in Leeds, we've led on the IBS BSG gut guidelines and functional dyspepsia BSG gut guidelines, which are, again, international guidelines. Also with Alex, I'm actively part of a Northern research group, a Northern powerhouse for functional gut research called Frontier. I had an opportunity to be at one point clinical lead for gastroenterology, clinical governance lead for gastroenterology, but also became clinical nutrition lead at one point because nutrition and neurogastroenterology are intimate bedfellows. So I began to become aware of the nutritional nightmares in neurogastroenterology conditions. And also I put this rather pompous phrase, nosological negotiations, also hit the ground here at a time of some emerging new conditions, which have been very challenging for us to traverse as a profession. One of the things here was escalation into invasive feeding. Together with Prof Simon Lau from the IFU, and again, John McLaughlin, we put together some guidance on when and when not to do jejunal feeding for patients with neurogastro problems. And also, most recently with Simon, we put together a European-wide joint parenteral and enteral nutrition and neuromuscular neuromotility position statement on parenteral nutrition in this group of patients. I was interested in Pauline. I've had some joint patients with who've had this hypermobility condition, which is a fairly new condition. We don't know what the genetics of it are. The actual phenotype has been recurrently reconstructed. You could say the biomarkers are bendy, and it's had a whole load of unproven associations with it. But what's certainly been true is an absolute tsunami wave of referrals to intestinal failure units across the country in the UK with this condition compared with other parts of the world, although that is growing now. And it doesn't seem to be purely biologically driven, that. What we're beginning to understand of the condition is this group of patients are particularly prone, again, full circle, to pain, hyperalgesia, and prone to more anxiety. And with this interesting social media context we're in as well, a lot of disinformation out there. Certainly what's true is this group of patients have greater interoceptive sensibility, a heightened awareness of what's going on inside. There's an overlap with fibromyalgia and CFS-ME, and quite possibly, therefore, either a nociplastic or small fiber neuropathy underpinning to the pain predisposition. Patients are more likely to have a hypersensitive esophagus if they've got reflux, and they're no more likely to have a motor abnormality than other patients. In fact, if they've got POTS as well, they actually have rapid gastric emptying. So what's emerging for this group of patients is they've got disorders of gut-brain interaction. They tend to have a fear avoidance response to that, and they're more likely to develop an avoidant restrictive food intake disorder and malnutrition as a result. This has been a very challenging emerging nosological negotiation for our subspecialty, and was able to lead with some early guidance in this area about how best to manage them. But watch this space. I'm also pleased to tell you I'm part of a working group developing a full BSG guideline for this presently. And we've also just submitted an abstract to the BSG this year of a multi-centre UK IFU survey. And a little bit of early breaking news is that a lot of patients with hypermobility being put on PN is not driven by nutrition, but more by symptoms. And there's a lot of harms patients are coming to in this group. So important emerging data. But there's so many other fascinating things that have begun to emerge in my time in neurogastro. Pauline's already alluded to the gut microbiome, what I'd like to describe as Doctor Strange in the multiverse of madness, because it's also such a new area that it's been very susceptible to a lot of unregulated industry and rabbit holes of misinformation. And the most recently, together with John and one of his research fellows, beginning to explore this fascinating interface with chronobiology, and colleagues, particularly Prof. in Liverpool, who were looking at the fecal volatone as an indirect marker of what's happening with the gut microbiome, how that changes over time. And then with some colleagues in Leeds, again, very, very hot off the press, this hasn't even been published yet, a new emerging condition called RISH, restrictive intake self-harm, which is a subset of disordered eating in neurogastro patients. I was able to get a pump priming pilot study funding from Pseudo-Obstruction Research Trust to look at patients who have pain related to small bowel feeding. This is, again, a growing problem for us in the neurogastro-nutrition interface. This is Hazel, who's one of our research dietitians here, with a unique approach to exploring this with two pumps, one where the feed's going all the time, the other where we're randomly varying the rate and volume of the feed and exploring what the patient's symptoms are. And it's covered, so the patients and the dietitian are blinded. And we've proven with this study that it is feasible to adopt this approach for this group of patients. It's clinically useful because in the patients we studied, there was no relationship between what the feed was doing and what their symptoms were doing. So more of a centrally mediated mechanism again. And it was acceptable to the patients who went through it. So again, we've submitted an abstract to the BSG. This is all very fresh stuff, and hoping in the future to look at some multi-center larger studies with this unique diagnostic tool. But lastly, just to say this is a challenging area, and there's a lot of emerging data now as well to say that gastroenterology is the major physician specialty at highest risk of burnout, and it's been described as a pandemic level in gastroenterology. And those of us who work at the nutrition neurogastro interface may be more at risk and more susceptible than others. So another project we've just started up recently is working with a GI psychologist, and rather than just a patient-facing role, we're looking at, well, how do we care for the carers? So we're about to start a series of facilitated reflective practice workshops with GI consultants, and we're going to hopefully look at measures beginning, during, and at the end of that to see if it helps some of the burnout type features that are at risk. So that's my brain gut odyssey, how I became an enteric electrician. My grandmother told me when I was little, you wouldn't get these stomach aches if you just chewed your food properly. And I just wish it was that simple. But this is an endlessly fascinating area that I'm very grateful to be a part of, working with fantastic colleagues. And thank you once again for the opportunity to share my research and my involvement. And I'm happy to take any questions. Thank you.
Well, thank you, Peter. That was excellent. Right. Yes, did anyone want to jump in straight off the bat with a question for Peter following that excellent talk?
Nothing's in the chat, Pete, but if I may
Thanks,
ask
Ben.
a question.
Yeah,
Peter.
go ahead.
Just wondering around, you touched on kind of misinformation. Is that a big threat and a big thing that you see when people kind of present to you? Yeah, interested in your thoughts on that.
A massive problem, I've got to say. So we see it where patients are sending away stool samples and hair samples to very pseudo-scientific looking organisations who will claim to tell them exactly what's wrong with their microbiome, exactly what they're allergic to. And all they've done is have their wallets biopsied because it's complete rubbish, and it sends them completely down a rabbit hole. So that's one area that's very problematic, and we have to often unpick a lot of false information people have been given. And the other is, whereas patient support groups should be supportive, and they often are, there are some patient support groups in some of these emerging conditions that are sometimes led by folk who aren't always very helpful in terms of the advice they give out, either in terms of some of the complications that they should be looking out for.
Thank you.
Thank you, Peter. Yeah, that's very, very helpful to know. So I think one of the things I was going to ask kind of picks up off the back of that question that Ben just raised. So you mentioned around the first time you saw an IBS patient back in the early stages of your career. Do you think there's been a more positive shift towards attitudes towards patients presenting with difficulties associated with IBS since then, or has it largely stayed the same and we're still fighting a battle?
I'd love to say yes.
Yeah.
I think the realities of the NHS means that there's more pressured clinic appointments, less time with people. And to be honest, to be fair to that registrar I met, he probably only had 5 minutes to see the patient. Sure. And but you can still be kind in 5 minutes rather than cruel. But so I do think those factors are getting worse again. It is somewhat stigmatized and trivialized in the wider media as well. But it's at a time, to be honest, as well, where we actually have more effective approaches than we've ever had before. So whereas there used to be a lot of therapeutic nihilism, we can modulate the microbiome. We do have effective neuromodulators. We know what to do with diet much better. And some simple things can be transformative for some people's lives and improve their quality of life. So, there is a mismatch, and it's still an ongoing fight, really, to get IBS and other new DGBIs on the map.
Sure, that makes sense. Thanks, Peter. Pauline, you've got your hand up. Would you like to come in?
Thank you, Peter, for your excellent talk. With the hypermobile patients, it's actually really difficult. So do you think you can find pathology and then treatment for these patients? I mean, most of them are just a little bit hypermobile, normal end of normal people, but then you obviously get the proper Ehlers-Danlos. They're different people altogether. So it must be a very tough nut to crack.
Yeah, it has, and creating a national crisis without understating it in the intestinal failure unit scene, because these are very high-risk interventions where people are having parenteral lines, parenteral feeding, and what the data is showing us is that this group of patients, compared with any others, they're getting more infections, more opioid use, and they're not actually translating into improved quality of life. So a very high-risk area, and no evidence of intestinal failure. That's the key thing. The tests that have been done, the studies that have been done, show that patients actually have a functioning gut, and it's pain and distress driven. And a lot of these patients are going on to parenteral nutrition who have a normal body weight and no signs of malnutrition. So it's all very distress and pain driven at the moment, seems to be the evidence. So it's something we're beginning to understand, beginning to get a grip with. But it's been this fascinating emerging condition on my watch, as it were, trying to approach it both compassionately, but in an informed way, and a lot of mythology has outstripped the science, which takes a bit longer to get out there.
Yes.
Thanks, Peter. Thanks for your question there, Pauline. Okay, was there anything else? Or did anyone want to raise any other questions, any queries with Peter? We've got just a couple of minutes before we have to end the session. I think one of the things I was going to raise just while you were speaking towards the start of your talk, Peter, was just if anyone had ever been in touch about the nominative determinism that you had with Paine on Paine being in pain. I thought that was great that you managed to mention that one.
Yeah, it's my proudest moment that I got into panels of improbable research. They also give out the Ig Nobel prizes for the most stupid research as well. Thankfully, I didn't get that one, but
No. No, there's still time, but no, I'm sure we won't, Peter. But yes, that's absolutely brilliant. We've had a thanks everyone for putting some great feedback in the chat as well. Just a lot of general thanks for you there, Peter, saying great work. Thanks for pushing positive research, bringing a bit of pushback against some of these, the companies that are trying to spread this misinformation about the gastro conditions. So yes, just a big congratulations. So I think we'll wrap up the session there. Thanks very much, Pauline and Peter, for those two fantastic talks. And thanks everybody for joining us. It's been a really great afternoon. I'll be in touch with recording for the session so we can share around any social media platforms you want to, any of your communications channels. And we look forward to seeing you at the next inaugural lecture, which I believe will be towards the end of March. So I'll be sure to get that out to you as soon as I can.
Thank you.
Thanks,
everybody.
Thanks very much.
Bye, everybody.
Bye now.
See you all soon. Bye-bye.
Bye.